Good evening. Welcome to the Ask Me Anything with Dr. Twyman. I'm a board-certified cardiologist. I help people at Apollo Cardiology, my practice in St. Louis, Missouri, prevent heart attacks and strokes. My practice has been open since 2019, and we have been focusing on the early detection of endothelial dysfunction. Atherosclerosis is more than just looking at cholesterol, and have been talking about these topics on social media since at least 2019. So I've been over 50 podcasts. So if you ever search YouTube, I have quite a few podcasts that go in more depth. Some of the better ones are the ones I've done with Dr. Gabrielle Lyon, Dr. Drew Purehit, and then also I did Dave Asprey's a few years ago. So if you're interested in learning more of those topics, go search some of my older podcasts. So the way this works is every Monday morning I put a story in my feed where questions can be asked. I'll answer everything I can that isn't a direct medical question, asking for dosages of drugs for a particular issue. But I'm here to try to educate you on vascular health. Vascular disease is still the number one thing that unfortunately kills people earlier than probably should. And if you understand how your vascular system works, maybe you too can reduce your risk of having a heart attack or stroke. So with that being said, we'll jump into the questions tonight. First question up tonight, is it unsafe to continue hormone replacement therapy after diagnosis of diastolic congestive heart failure? The short answer is this would require, medical knowledge of your medical conditions. Other than diastolic heart failure, hormone replacement therapy, it means many things. So what exactly, is this just testosterone? Is this something else? And is it affecting blood pressure? That's usually the biggest concern, that some of the hormone replacement therapy can increase water retention, which then raises blood pressure. So is it unsafe? Not necessarily. And the other concern would be what is causing diastolic heart failure. From a quantum biology standpoint, this is an issue with your mitochondria being able to produce energy and allowing the mitochondria and the heart cells to relax. So that's what you have to kind of work on, is figure out why do you have diastolic heart failure? And the second other question is, what are you trying to optimize with hormone replacement therapy? Are there any other options besides a statin if you have family genetic high cholesterol? So if you're speaking, do you have familial hyperlipidemia? Yes, there are many options other than a statin. The main 4 classes of medications are statins, but there's also ezetimibe, there's PCSK9 inhibitors such as Repatha, Praluent, and elesclerin. And then there is also the Nexletol, which is known as bempedoic acid. There are some other more niche use cases for people who got homozygous familial hyperlipidemia. But if you have that, you're going to be working with somebody probably in an academic center, because a lot of those drugs require special licenses basically to be able to prescribe those. But many options, and it's much more about, do you have vascular disease determines how aggressively to start treatment. But if you have familial hyperlipidemia, the sooner you treat, the lower your risk. Think of it as pack years of cigarettes. If you stop smoking, the less risk of heart disease or lung cancer. Next question, only option is statin if lipoprotein A or lipo-B are high? No. If you go back to the previous question, I often use ezetimibe individuals, who are hyperabsorbers of cholesterol. If their ApoB is, in the 90th percentile or greater, so if they got an ApoB of 140, 150, oftentimes PCSK9 inhibitors are going to be useful because they can potentially lower the lipoproteins 40 to 50%. And then bempedoic acid, not as strong as a statin, so rarely will be monotherapy for many people, but many options other than statins. And I always tell patients, statins are tools. There's no, magic that you must take a statin if you have high cholesterol, but you talk about risk, benefits of any type of intervention. What are my thoughts on ribose to replenish cardiac ATP after cardio? Possible. It's part of the awesome foursome Dr. Sinatra developed many years ago for patients with cardiac conditions. Mainly was using for patients with heart failure or atrial fibrillation. But could it possibly help with cardio recovery? Yes, possibly. If hemoglobin A1C is high, is it more likely with plaque formation? Possibly. particularly if you've also had high insulin, going along with that. High blood sugar and high insulin are two large risk factors for damaging the endothelial glycocalyx, which is the lining of the arteries that protects the underlying endothelium. If that coating gets damaged, the person's more likely to develop plaque. So if you have chronically high blood sugars and you have a high A1C, yes, that is one of the risk factors for developing plaque in the arteries. All right, probably not an easy way to totally quantify this, but what is worse, junk food or junk light? If I actually had to probably judge between the two, I'd probably say junk light, because most people understand what junk food is, and that it's not necessarily going to be optimal for them to eat it. Most people are unaware of how much junk light they're being exposed to. So if you've been following me for any period of time, you've probably never met me without my glasses on if I'm inside. So junk light is probably worse long term than one junk meal. What are my thoughts on taking progesterone if you have coronary artery disease? Assuming you're a biological female and you're menopausal, it is something that you may safely utilize if you're under the care of somebody who understands how to dose it appropriately, but not something that I would be concerned about for most women to take. Question, why do you not take acid inhibiting meds for GERD if looking to reduce plaque? So this question probably comes from somebody who's heard some of the work of Dr. Nathan Bryan. Dr. Nathan Bryan is a world expert in nitric oxide and nitric oxide product development. Nitric oxide is critically important for vascular health. Your arteries release nitric oxide to dilate. Nitric oxide helps support healthy blood pressures. It helps prevent cholesterol from sticking to the arteries, prevents white blood cells and platelets also from sticking to the arteries. So without nitric oxide, your arteries become stiff and eventually may develop plaque. If you take stomach acid blocking medications long term, you affect endothelial nitric oxide synthase. You have an effect on enzymes that help produce nitric oxide. And you also have an issue where your body can't convert nitrites that were developed from the nitrate reducing bacteria in your saliva if you don't have stomach acid. So it's kind of a double whammy. Your arteries potentially get stiffer and it may raise your blood pressure. So, if you need the medication short term because you have a gastric ulcer, you have H. pylori, you have Barrett's esophagus, maybe a different story. But you have to look at, are your arteries getting stiff? Do you have issues with nitric oxide? Is your blood pressure becoming abnormal because you don't have stomach acid? Next question. I think this is, don't know exactly how old, but it says Hub 49 MI 11 years ago. So hopefully it doesn't mean that the person had an MI at 38 years old, but if they did, that is very unfortunate and very early. There's generally going to be significant residual risk factors for those type of individuals. LPLA, familial hyperlipidemia, 9p21, the heart attack gene, something else is going on in those individuals. But this person has 2 stents. What are the best labs and imaging to reassess risk? And the person has that family history that their father had MI and died at 71. So it's somewhat of a longer process than probably Instagram would allow me to kind of go through. But this is something I do with every single patient that works with me who has either vascular disease or a strong family history, is assess what is their current atherosclerotic burden. We look at carotid intima-medial thickness scans to see if the person has carotid plaque or carotid inflammation. If they've already had coronary stents, there's generally no reason to look at the coronary arteries unless the person's having symptoms. We look for abdominal aortic aneurysms with ultrasounds. We look for peripheral arterial disease with ankle-brachial index testing. Then we look for the arterial stiffness markers, pulse wave velocity. We look for the endopat, which is the reactive hyperemia index. Those are essentially the stress tests for the arteries to see if your arteries can dilate and produce nitric oxide. And then labs, whole myriad of them, by 300-400 labs that we assess in patients that are new to our practice. But they generally break down into 3 buckets. Labs that affect nitric oxide, labs that contribute to inflammation, oxidative stress, and then labs that affect the lipoproteins. In that case, we're looking at the cholesterol balance test to see if the person's a hyperproducer or a hyperabsorber of cholesterol, looking at ApoB, looking at the lipoprotein NMRs to see the LDL particles. Do you have small LDLs as well? And then, based off of the other things we find or in our lifestyle questionnaire, then we add on other labs or imaging tests. And then the last question tonight that was pre-submitted, and then I will answer the questions in the comments if there are some. So, is it safe to take DHA if you have coronary disease? The short answer is possible, but again, I can't provide one-on-one medical recommendations through this type of form. But it does somewhat depend, why the person's taking DHA to begin with. In my experience, it may be been more beneficial for women to consider it than men. It does provide some androgens. So in women, it may increase testosterone. In guys, I rarely see that it has much effect on testosterone. But if you have effect on testosterone, it may affect blood pressure. So you do need to monitor that if you have a history of coronary disease. All right, so question in the comments. Have I ever heard of TECA that helps with plaque formation or progression? I have heard of TECA. I've not seen any great studies that confirm that it actually has much effect on vascular plaque. But if there are some that I'm not aware of, happy if you send me any links to something and I'll take a look at it. How can you activate cellular turnover naturally? Optimize your sleep. That's the number one way to do that. And how do you do that? Optimize your circadian rhythms by getting proper light signals in your eyes and on your skin. And then from a nutrition standpoint, eat a seasonally appropriate diet. So what food grows in your region, and don't eat when it's dark out. Ideally, don't eat 3 to 4 hours before bed. That's the natural way to start affecting mitophagy, autophagy, and apoptosis. Well, those are some great questions tonight, guys. I appreciate them as always. It always helps me, stay sharp in answering questions from my patients that come work with me at Apollo. If you're interested in working one-on-one with me, my team is happy to discuss. I am booking 2 to 3 months out into the future. So if you're interested, don't wait too long. And if, St. Louis is something that's out of your ability to travel to right now, I do have a community on school that I teach in. I'm providing a lot of information as I learn it. So teaching myself a lot of, pretty cool AI tools to help synthesize and distill some of my ideas from my prior podcasts that I've done with some people. I just recently uploaded one that I did with my podcast with Dr. Line. Has some pretty cool infographics on vascular health and muscle-centric medicine. I'm going to be doing an hour-long Ask Me Anything this upcoming Friday at, I believe it's at 1 p.m. Central Time, maybe 1:30 Central Time. But that's for the people that are members of the school community. And then in that case, we're able to do a little bit more one-on-one and go back and forth on questions about people's actual cases. Still can't prescribe things to people that are in that group unless they're my actual patients, but I can go deeper into the people's questions there. So there's a free 7-day trial if people are interested. The website is drtwyman.com/school, and hope to see you there. All right, and then a question that just popped up in here. Do I have anyone I can recommend in Southern California? I don't know what that question is in relationship to. Is it a question about a cardiologist? What is the issue? Are you looking for a integrative, functional medicine cardiologist? You're looking for somebody who understands quantum biology. So I don't know exactly what somebody in Southern California would need, but let me know in the comments or send me a message on that. So as always, appreciate you guys' time and attention, and I will see you next Monday, 6 p.m. Central Time.